This is Dave Prologo and our group here at Muhimbili. And we started advanced interventional pain management practice actually a couple of days ago. And we've done some cases and we've seen quite a number of patients. And so today we're going to talk a little bit about advanced interventional pain management. I'll give you the wider context. And then we'll talk about some of the cases that we did here. And on another day, we might be able to hit these other portions of what is becoming a very large subspecialty of interventional radiology. So globally speaking, pain management is something that we will all see. And I'm very happy we picked today to do this because we've already seen patients and we've already seen a lot of the things that I'm going to talk about translates into life. And what you'll find is that patients who have pain oftentimes have seen somebody else, palliative medicine. They might have seen their primary physician. They might have even seen some other kind of pain physician who's either giving them medicine or might have potentially done something. Or a lot of patients that we see here have done physical therapy and even psychological support. But where we fit in is here, right? Where we fit in is imaging and imaging guidance. And I'll show you what I mean by that. But plainly said, we want to match up what the patient is saying with what the image shows, and then ask ourselves, is this something we can use image guidance to access some pain generator and then do something? And what you'll find is that because we have the ability to access so many places in the body with such exquisite precision, that there are pain generators most people cannot get to that we can. And that allows us to have a special effect on a lot of people who otherwise don't have options. Some quick history. This is a slide that must be 12 years old at this point. How all of this came about, right? So it came about because these are journals from the formal anesthesiology, pain medicine subspecialty. And I included them here. This must have been, this is approaching 20 years ago now. But the point was that they had imaging on the front of 9 out of 12 of their monthly journals. And to the point that they were realizing that by applying imaging guidance to the things that they were doing, they could broaden the spectrum of the things that they could do, and they could increase the efficacy and improve the safety of the things that they were doing. So that was something that was happening on its own. And then over here, for us, we were learning how to do interventional radiology. So it was our specialty to use image guidance to do many, many things: treat liver disease, do tips, put in filters, all the kinds of things that we're learning, putting in perm casts, etc. We have the greatest skill sets here. These folks were trying to learn that on their own. And so what happened was we took all of this from what we know how to do, how to treat cancer, how to use image guidance. And then we taught ourselves about pain and realized that we can reach pain generators. And all of these things combined to create new procedures that did not even exist 20 years ago and would not have been available to patients. And now, since the time that this slide has been made, has evolved really into its own independent section of interventional radiology. So who cares about any of this, right? We care because it's interesting, but it turns out that a lot of people care. This was all happening. Hopefully you can see my mouse. This is all happening during a time that there was a worldwide, and still is, a worldwide opioid crisis. And that opioid crisis led to many laws and many guidelines that prohibited or made it difficult for patients to get pain medicines. So now you had millions of people with pain who had difficulty getting medicine, or the medicine was dangerous for them, and laws and guidelines that called for something else, some other way to treat pain. So while this thing was evolving, interventional pain management in interventional radiology, the patients were simultaneously looking for new options. And so I always compare this to if you decided to open a restaurant and then all of the sudden there were laws that said everybody has to go to a restaurant. So everybody started coming to us for these procedures at the time that we were evolving and learning and developing these procedures. So a lot of the patients cared for that reason. This is supposed to represent the hospital administration. They definitely care. They care not only because the procedures are revenue generating, which is this, but also because they decrease length of stay. Many patients who come to the hospital because they have pain are difficult to discharge unless you have some creative intervention, which is what we have. So the hospital administration loves it because you can decrease the length of stay. As interventional radiologists, you will learn that if you start to solve difficult pain problems for patients with pain related to cancer or even not related to cancer, you will generate what I call halo business. You will find out that these relationships lead to other procedures that are more standard. It gives us the chance to diversify. It opens new doors for us. And then, we include this as a symbol of hopefully all of us have gone into this business to try and put some good into the world. And certainly the management of these difficult pain syndromes accomplishes that. Some people will be mad. So it's important. And the very first thing that we talked about here, even before I got here, was is there somebody else who already thinks this is their practice and their quote unquote turf? And in those cases, you have to be cognizant of that and careful because you don't want to block any referral streams or create any conflict. So you have to understand who else wants to do this, what they can do, and how you can be collaborative and share. But most importantly, the patient cares. The patient is somebody who is living with some kind of pain, and most of the time feels like nobody cares about them, nobody understands the pain that they're having, and nobody can do anything. And so the person at the center of all of this is the patient. That's the person you will affect the most. So that is a segue into an entirely different topic, which I'm not going to cover here, but I want to mention in one slide. We are going to cover this at the SIR annual meeting. It is becoming more and more important. As we are busy, we sometimes forget about the patient. And so this concept of humanism in IR is to bring us back and to ground us again and realize that this person that you're talking to is not just a source of revenue or a source of an interesting potential procedure, but somebody's loved one, somebody's mother, somebody's sister, father, brother, relative, and may not necessarily be straightforward. So it's our responsibility not only to come up with some kind of procedure, but it's our responsibility to take care of this patient from the day we meet them until they don't need us anymore or for a lifetime. So we don't just make binary decisions and or do procedures and discharge patients. We follow them over time and we take care of them over time and we listen to their story. So during the last, I would say, 12 years, this idea of advanced interventional pain management has absolutely exploded to the point where it's difficult to present it all, impossible to present it all in one talk. And so we came up with this idea of categorizing the potential procedures to help somebody when a patient presents to you with pain that you don't know, because this is what happens. They walk into the clinic, and I know all the people in the room with me now realize this. They walk into the clinic and they have some kind of pain, right? And you now, in 2024, as an interventional radiologist, have maybe 100 procedures at your disposal, but you have to figure out which one fits the patient's pain. So in order to organize this in your brain, the first two questions I would encourage everybody to ask themselves and or the patient and the team are, A, is this a cancer patient? And B, is this a spine problem? If you can answer those two questions, then you can put the patient in one of these four boxes. A patient who has cancer, so it is, yes, a cancer patient, and then it's either a spine problem in a cancer patient, or it's outside of the spine in a cancer patient. The other option is that it's not a cancer patient, the pain is not cancer related, and it's either in the spine, which is super common, and a lot of these are the patients we've seen in the last few days, a non-cancer related pain generator in the spine, or it's a non-cancer related pain generator outside of the spine, peripheral neuropathy, for example. Point being that you can organize your thoughts when you talk to the patient, put them in one of these four boxes, and you can now distill and reduce the number of procedures that you have to consider to help them. This is what it looked like in 2018 when we published this paper. There was basically one thing that you could do for patients who had metastatic lesions in the spine. There was an algorithm to follow for patients who had spine-related pain that didn't have to do with cancer. There were a list of things, essentially nerves, that you could target in patients who had pain that was generated outside of the spine but not related to cancer. And outside of the spine, cancer lesions, metastatic pain, was essentially ablations and nerve ablations. Just between 2018 and 2024, I think these options have essentially doubled because of the development of procedures like genicular nerve ablation, basivertebral nerve ablation. So we're not going to go over all of this. We'd have to spend 2 or 3 days to cover all of the evidence and all of the potential procedures. But this is the context in which we are operating, right? So each one of the patients that we see falls into one of these boxes and therefore has options inside of that box. So we don't have to get confused and try to think about every potential procedure or device that exists. We can narrow it down. And we're going to go over some of the patients that we've seen here. We've already done some procedures, thankfully. And we'll go over some other cases just as examples to show you how exactly this works. So already, today's Thursday, and already here at Muhimbili, we have seen patients, the majority of the patients that we've seen have been non-cancer patients with spine-related pain, right? We have also seen patients who are not cancer patients who have pain generators outside of the spine, like knee pain, for example. We have also seen, and hopefully this speaks to the amount of impact you can have if you become interested in this portion of interventional radiology, because this is 3 days worth, right? We have also seen patients who have cancer-related pain that's outside of the spine, all in the last 3 days, some of which have already undergone procedures for us. We're going to skip this because in the old days, we had a list of things that you could do, but now we're working out of this categorization and this algorithm. So this list is much less helpful, right? I think I've made the point that pain is everywhere. So we weave this idea, it's impossible to treat a pain patient without weaving this idea of either humanism or the biopsychosocial model of pain. And what I mean by that is there is some sort of innate human tendency, if we don't know right away what is the pain generator, what's the source of the pain, if we can't make sense of it right away, there's some human tendency to think that the patient is maybe crazy or they're exaggerating. But really, it's our responsibility and it falls on us to find out what's happening with the patient and get them help, even if it's not us, even if it turns out that we have to get this patient to the right subspecialist like a surgeon. We've seen some patients that we think needed surgery and not interventional radiology. Or even if we do think somehow there's a psychosocial component, we still have responsibility as a human being to help them. So we don't dismiss anybody. The algorithmic models to the approach of pain, in addition to categorizing this, in addition to is not the right word. Once they're categorized into one of those 4 boxes, then we take this algorithmic model, one of these two, to move forward in order to do one of 2 things, which we've talked about a lot in here in the last 3 days. The first one, cornering the source, or sometimes said colloquially as painting it into a corner. And what this means is that something is responsible for the patient's symptom. And if you don't know what that is, then it is incumbent upon you to start doing some investigation. The simplest example of this is a patient comes in with nothing but a symptom. Many times we'll order imaging, right, to try and understand what is the source of the patient's pain. I see many, many, many patients who have come to me with years worth of pain, and you ask them, why do you have this pain? What is the cause of this pain? And they say, I don't know. It's unbelievable, right? Almost no other portion of medicine would ever tolerate that, right? If a patient had a trauma, for example, and you wouldn't say, that you don't know why their arm is broken, or you don't know what to do, right? You wouldn't accept that. And you certainly wouldn't do anything without being able to answer and define what the problem is. And it always astounds me how people will have pain for many years without knowing what the cause is. So once we put them into one of those 4 boxes, our next order of business is to define the pain generator. To be able to answer that question, you have pain because you have hypertrophic facets. You have pain because you have a metastatic deposit sitting on a nerve. Or you have pain because you have pelvic congestion syndrome. Whatever it might be, we have to have an answer to that question. And then this is why I was excited to give this talk to you all after we've seen these patients, because we've said this several times already. We've said B several times already. And that is that you're going to systematically and sequentially address multiple contributors of pain, especially in the spine. In the spine, there's more than one pain generator. And so you might take care of the facets, but still they have some spinal stenosis, or still they have some discogenic disease. So we don't just do one thing, we chip away. So same point, just in a figurative demonstration or a figurative illustration, how more than one thing, for example, facets, we might do an epidural, sacroiliac. These things can all contribute to the symptom the patient is describing to you. So we're not one and done, right? We take care of the patient over time. This algorithm came from that top left box, which was patients who present with non-cancer related pain that is originating in the spine. It's a complicated thing. The spine is complicated. There are many pain generators. The very first question we ask, and I could certainly ask in this room, what's the very first differentiator? We divide these patients into whether or not their pain is axial or radicular. Are they talking about pain that is in their low back or somewhere in their back and staying there at the belt line? Or are they talking about leg pain? Are they talking about leg pain that originates in the back? Once you make this differentiation, then you've got 2 routes to go down. The one we've been going down most commonly here, which is probably most common in the world, is axial back pain caused by facet hypertrophy. We don't do facet blocks anymore. I'll tell you why in a second. And then facet interventions. This description, non-radicular low back pain, and lower extremity pain. So, but not radicular pain. They'll have, well, that's why it says non-radicular, right? So non-radicular low back pain, but they will potentially say that their lower extremities have numbness, and they'll rub the anterior portion of their legs, their thighs, and say that their legs feel that way, right? They do have significant pain, and they often don't respond to these other things, which again, we have seen in here over and over, right? This patient's gone to physiotherapy. This patient has medicines, et cetera, failure of response to conservative management. This slide is again and again addressed in the literature. The point being that any one of these pain patients does much better when worked in combination with all of these other things. So we don't want to necessarily take over the patient, because let's be realistic, we don't want to take over the patient. We're busy. We have other interventional radiology procedures to do, right? So we don't necessarily want to take the patient over globally from a medical standpoint. And second of all, patient will do better if it's a multimodality treatment. If we have a patient that we treat who then also begins to exercise or have chiropractic or physiotherapy and medical management, when you combine all these things, the patients do better. And this isn't just some story or some subjective comment. This is something that is proven in the literature over and over again. People don't do as well with monotherapy as they do with multimodality therapy. As far as interventional radiology goes, this is probably the most important slide as it pertains to pain. We can greatly simplify what we're doing in those different boxes by finding a radiological manifestation that correlates with the patient's pain. It sounds simple, but as we try to accomplish the things on the previous slides, as we try to define the cause and then address it, in our business, that means finding something on imaging that corresponds to the patient's pain and then bringing them to image guidance so that we can address that, access that, and do something. This is much different than a less effective approach that we might see in other specialties, whereby somebody comes in with a symptom description and then a physician just starts doing things, right? We don't do that. We want to find something on the imaging. We want to put a name to the cause, and then we want to access it with imaging guidance and do something. So still talking about facet pain on the axial side of non-neoplastic back pain. So here's an example of that, right? If a patient comes to us with axial back pain that is non-radicular in nature and has been going on for a while, is refractory to other therapies, we see these hypertrophic facets. Now we've got a reason for the patient's pain. And the important thing for us is that these two slides are just, everyone I think probably already knows this, but these are normal looking facets, right? So these don't look bad. These don't look bad. These look terrible, right? So what happens with facet degeneration is the same process that's happening other places in the body: hypertrophic bone formation, narrowing of the articular surface, subchondral cystic change, etc. Essentially, inflammatory osteoarthritis. This is what it looks like in the cervical spine. But here's the important target. So if we're using facet pain as our example of what we're doing here, we have done the following. We've listened to the patient. We have found a radiological correlate in facet hypertrophy. Now, the next step is to identify something on imaging that we can access and do something about. Anatomically speaking, each one of these exiting nerve roots is giving off a posterior branch like this and like this, one above and one below. And that is the medial branch. That medial branch carries sensation from this arthritic facet. So now we've got a cause. Now we've got something that we can access on imaging and do something about. And this is how we're going to manage every pain symptom in interventional radiology. This is the fluoroscopic approach, which we have not talked about in here yet. But I will take the time to say that in order to get to this projection, because this is the fluoroscopic approach to medial branch, in order to get to this projection, the first three things we did We lined up the posterior elements. We lined up the inferior end plates. We put our target in the middle of the screen. Then we obliqued to our target. We would do that every time, every time, every time. And in this particular case, the target is the junction of the superior articular facet and the transverse process, which we've gone over the CT target where it is on axial images. This is what it looks like on fluoro. This is what it looks like on the lateral. You can imagine this is the neuroforamen, right? And the exiting nerve root is throwing that medial branch and goes right here. And so this radiofrequency ablation probe interrupts the signal to the painful facet. Just another example of a lateral close-up in a different patient, neuroforamen, multi-level. We have CT. I'm going to talk about CT in a second, so we don't really need to dwell on these images. Same procedure in the cervical spine. This slide snuck in there. I included this many years ago. I was a fellow in this picture. And so this is what it looked like then, and this is what it looks like now. I mean, this generator looks very much like the one we have now. And these are the cords attached to the radiofrequency ablation probes with the patient prone. So facet intervention outcomes, which we've been, again, seeing so many facet patients in the last couple of days, so I'm glad we started with this. The intra-articular injections, they don't work. They don't last, and they're no greater than placebo. So we try not to do those for therapeutic reasons. They're really not worth putting a patient through a procedure just to try and inject either intra-articularly in a facet or to inject the medial branch. It's a day or two of relief, and it's no better than placebo. Unlike radiofrequency ablations of that medial branch, almost everybody reports significant improvement in symptoms at 6 months and 12 months. So a very powerful procedure at our disposal. This is my mom. So I wanted to quickly cut and paste these images in here to show if you think about, I'm going to flip here, so don't get dizzy, but I think it's going to be worth it. If you think about this down the barrel view, right? We went through those steps. We took this down the barrel view. We put it at the junction of the superior articular facet and transverse process. We hit the bone, and then we walked it over. We haven't done this yet, but we will. This is how we're going to do facets in fluoro. But if you keep this image in your mind and then come to the CT image, right? It's the same thing. It's the junction of the transverse process, and coming out of the image is the superior articular facet, and coming back and around to these hypertrophied facets is the medial branch. So we set the RFA probe there, one on each side. If you think about this side, the nerve root is coming out, but it's already thrown a branch back here. And when we interrupt that signal, the patient feels a lot better. Other things to consider on the axial side are sacroiliac pain. Sacroiliac pain is really pain over the posterior superior iliac spine. People will point to this, and I think we haven't had anybody who really kind of was a slam dunk or didn't have some other cause for their pain, but important to keep the differential diagnosis in mind. We can do bone scans, we can look for arthritic changes on plain film, but the real test is an injection. So an image-guided injection to the sacroiliac joint under fluoroscopic or CT guidance that gives relief is diagnostic for sacroiliac pain. This is what it looks like again, greatly simplified in CT, right? Straight down into the sacroiliac joint, inject steroids and bupivacaine, ask the patient if they get better. And then the correlate in the sacrum to medial branch ablation is called lateral sacral ablation, lateral sacral root. So each one of these sacral exiting nerve roots throws out a lateral sacral root, and it's the same principle. You just address them with a radiofrequency ablation probe. And it's the same, this is an old slide, newer technology with promising results. There's still not a ton of data on lateral sacral roots, but there's really no difference when compared to medial branch. And so in the select right patient population, it's a good procedure. Now, discogenic pain. This is something that we've seen here, it's one of the things that can contribute to axial back pain. In the past, right, this is an old slide, we would go down this route of potentially doing discography and then some sort of intradiscal therapy, like there was something called nucleoplasty. There were people who injected ozone therapy and just all sorts of things, none of which seemed to have any real effect. But discogenic pain is still a contributor to axial back pain, and we have to consider it. Percutaneously, there is a new procedure called basivertebral nerve ablation. The approach is just like a vertebroplasty transverticular, and it's another nerve ablation, but it's the nerve that supplies the disc. And we'll talk next Thursday when we get another talk. I can talk a little bit more about that. Point being now that if you think someone has discogenic pain, like a patient we saw maybe an hour ago, then we have to consider either basivertebral nerve ablation or potentially surgery, or potentially a midline epidural injection. These are old slides. We don't really do discography anymore. We used to do that, inject CT and grade them, even inject lidocaine and have the patient walk around, all diagnostic for pain that's generating from the disc. We don't do any of this anymore. We look at the MRI, we see desiccated discs, and we use modic end plate changes to grade them and also to qualify them for basivertebral nerve ablation. So that is now history. So also over here as a potential, these are causes, right? Also over here on the axial side should be this non-specific epidural injection or midline epidural injection, which we're going to talk about in a second, for patients who have axial back pain and not one of these other causes. So keep that in mind. With that in mind, we take a pause and we make this great distinction. We just talked about what we can do for patients with axial back pain. What are the potential causes there? Now, what if the patient comes in and doesn't say, I just have low back pain that is by my belt or in the middle and doesn't go anywhere? What if they come and say instead, I have this back pain, but my bigger problem is this radiation down my leg to my outside of my ankle or to my knee? Now you've got radicular pain, and you have to ask yourself the following question from the previous slides. Is there something on imaging that I can find that corresponds for this patient's symptoms? And if so, can I access that and do something about it? And these are some of the greatest procedures we have. Oftentimes, it's a herniated disc that's sitting on an exiting nerve root that gives you a dermatomal. So in this room, we've been Googling and pulling up this image already maybe 5 times, right? To see what exactly the dermatoma is that the patient is describing to us, and then looking at their MR for a disc like that. We're all familiar, I think, with what this looks like. You've got a signal from a disc that is herniated and pressing on an exiting nerve root in a patient who would be complaining of right leg pain at whatever level this is. This is good for us because this is definitely something that we can precisely target under imaging guidance and do something. And what is that something? If we inject steroids here and we can decrease the edema in this disc, then we can hopefully, when the swelling decreases, reduce this back to where it belongs. The same mechanism of anti-inflammatory mechanism will decrease the signal in the adjacent nerve because that nerve is also inflamed from being pushed on by this disc. We can get to this very precisely with CT. In this, if this was our case, I would use CT to get right up next to this disc and nerve complex and inject steroid there to decrease that. If we wanted to do that under fluoro, we can also do it under fluoro. So I know that the trainees here at Newham Billy are getting tired of this repetition, but one last time, when we saw this patient, the first thing we did was line up the posterior elements, right? And then we centered the image, and then we lined up the inferior end plates, and then we obliqued towards our target. In this case, we hit the pedicle and we slide underneath for a transforaminal injection. Under fluoro, when you inject contrast for a transforaminal injection, you're filling the epidural space around the nerve. And this is what it looks like, right? That's not the nerve. That's the epidural. That's contrast in the epidural space around the nerve. So, Fabian. So, and this is what the transforaminal injection will look like under fluoroscopic guidance, if and when we choose to do it that way. So we put this non-specific epidural injection on this side. It does belong here, but it also belongs over here in the axial side, as we have seen. But for purposes of this talk, if we have a patient who's got radiculopathy and we think it's nerve-related, but we cannot see a specific level or a specific cause, then we might proceed to what's called a non-specific or a midline epidural injection. So the epidural space, I have to move this. The epidural space is this small triangle back here, and it's filled with fat, just like the fat that we saw surrounding the echo was coming from. So there is a distinct method that we use to access the epidural space with a needle under fluoroscopic guidance for the purpose of injecting medicine. This is what it looks like in the steep oblique position. This is an important image. This is contrast in this space going up and down. It's a straight line. It's not contrast that has migrated anteriorly. You haven't pushed your needle into the thecal sac, which we don't want to do. Uh-oh. Sorry. I am proud to say that we did this morning at Muhimbili Hospital. And I won't go through the steps again, so if you guys are going to have enough of that. We obliqued for our target in the end. This is our down the barrel view for our midline epidural that we did a couple of hours ago. And then this is the lateral, steep oblique. And here's that straight line, right? So we know using loss of resistance technique that's, and then injecting contrast, there is some contrast anteriorly here as well. But the important point is that this is the anterior epidural space, and this is the posterior epidural space filled with contrast. And then we follow this with steroid and bupivacaine, but at no time did we violate the thecal sac and inject medication. So I think that this patient is going to do well. You can do this in the cervical spine under fluoro. It's a little bit more dangerous. Yesterday, everyone here, we talked about the angle you have to take because these posterior elements are angled down. This is a good example of that, right? This needle is angled almost parallel to these posterior elements. You can't just go straight down in axial projection when you're doing a cervical epidural. I'm going to skip that for a second. Well, the reason this is here, or if anybody remembers the 4 boxes still from the beginning, so far during this entire talk, we've been talking about the top left box, which is spine-related pain that is not in a cancer patient, right? And not related to metastatic disease. And that's just one of the 4 boxes that we've talked about. Don't worry, we're not going to go through all 4 boxes because we'd be sitting here till 4 p.m. But for example, or for illustrative sake, if you had no cancer and pain that was outside of the spine, that's going to drop you into that bottom left box, right? And essentially, that's the whole body outside of the spine, not related to cancer, and that's going to be nerve targets for us. And with our cross-sectional imaging and our techniques, we can reach just about every nerve or plexus that you can conceive of. And if that nerve is carrying pain or is damaged in and of itself, as is often the case for pudendal nerves, then we can reach those nerves using cross-sectional imaging, and we can interrupt them or inject them. So this is the first, I think the first idea of using image guidance to treat pain outside of the spine in interventional radiology. It started with pudendal neuralgia, which is a condition that young mothers would get after a traumatic childbirth. And then they'd be told, the reason I'm dwelling on this is because it really illustrates what we can do and where we belong in the grand scheme of things, because these patients were essentially told there's nothing that can be done. So you've got a 30-year-old mother who had a traumatic childbirth, now has pain, nerve-related pain, and no options. This is the prototypical patient for advanced interventional pain management, the prototypical patient for interventional radiology. So no longer do you have no options. We'll be able to get there and do something. And in the case of pudendal neuralgia, we can both inject and ablate these nerves using CT guidance. But these are outside of the spine, non-cancer related conditions. And in the recent years, in the recent 5 years or 7 years, this bottom left box has exploded. And I'm going to wrap this up pretty soon, but I want to leave you all sort of curious for more. But this is an old image, right? This is what we did. This is what we had in our toolbox for hip pain, which was an intra-articular injection, right? And we would be so proud to see this sort of band of contrast, and you would know you were intra-articular, and your lateral here to stay away from the femoral vessels. And for years, that was what we had. But using the same mentality that we used for pudendal nerves, the idea became, why can we not access any nerve that's carrying pain? And now we can access branches of the obturator nerve, branches of the femoral nerve, and ablate them for purposes of hip pain. And here at Muhimbili, this is an image from Alan Sog's paper that demonstrates how we can use CT guidance to access the nerve supplying the shoulder. So the principles are the same here. It's the hip, it's the shoulder, it's the knee, it's pudendal, it's whatever. We can get there with image guidance and do something. And just this morning, we did exactly that in a patient who had asymmetric advanced osteoarthritic change in her left shoulder. And we used CT guidance to access branches of the suprascapular nerve and axillary nerve for purposes of injection this morning, but we can also ablate. And on it goes, right? The other option around the hip now is something called a ping block, which allows us to use CT guidance to access a fascial plane. But point being that in that bottom left box are a lot of potential procedures for us. The celiac block is 30 years old, right? But it's not just the celiac plexus that is responsible for a patient's pain. So another Muhimbili patient, thank you, Moana, that we saw this morning, patient with cervical cancer, or yesterday's cervical cancer, who's got thickened mesorectal fascia here, as well as several fistula related to the bladder and intractable pain. So not going to respond to a celiac plexus block. But now we're talking about patients with cancer in that bottom right box, cancer that's outside of the spine, not the typical celiac plexus block, but we have other targets. All we have to do is ask ourselves, what is it that's taking this pain from this patient's lesion back to the brain? In this case, there are some pelvic splanchnic nerves that live here in the mesorectum, but also there's all these presacral nerves, also called the inferior hypogastric plexus. Point again being that we can identify them, we can put a name to the cause, we can interrupt the nerve signal, and we can offer the patient an option that if they didn't come across interventional radiology, they would not have. And so with that, I'm gonna stop. We could go on forever, and in fact, the SIR just had an 8-week or something, 10-week series on pain management. And even that, I don't think covered it all. So hopefully I've given you a broad context as to what the possibilities are in this space. And also made the point that there are general principles, regardless of which one of those 4 boxes your patient might end up. So I'll stop there and I'll take any questions if there are any. Nobody in this room asks questions. Anybody? Okay, Dr. Aza asking a question.
Yeah, so how much do you estimate the volume to be? Say for triamcinolone, we already know like it's not much volume.
Right.
Right. So in hospital, it's 8.
Right.
But how much, if at all, of puberty and
Right. So the question is how much volume? How do we decide how much volume? And I think the answer to that is twofold. The first part of the answer is how big is the space? How big is the space where we are intervening, right? So here. So in this patient who's got a herniated disc pressing on this nerve is the problem. We don't need triamcinolone and bupivacaine all the way up and down the epidural space. So this is a small space right here. So we might give 40 milligrams here and half a cc of bupivacaine. When we did this case, though, I don't know, maybe I lost it, but when we did our epidural, we are now accessing in the midline and understanding that there's a large area for volume, not only up and down the spine, but also anteriorly and posteriorly. So especially in a post-operative patient, there are suggestions that more volume is better. I'm not sure that I subscribe to that just yet, but certainly we put 80 milligrams in here and up to 2 or 3 cc's of bupivacaine. If we think about the cancer patient, right, then we have the second part of your answer. The first one is how big is the space? In this case, the space is pretty big, right? There's going to be a lot of room to inject in here. And then anterior to the sacrococcygeal junction, where there's the inferior hypogastric plexus, there's a lot of room. So, but it's not infinity, because the second part of that answer is, where does it start to go wrong? So the sciatic nerves are sitting right behind here, right? Here and here. So as you go up and down, these are going to start to migrate laterally. So you're going to stop way before that alcohol, in this case, starts to reach the sciatic nerve. So it's a combination of how big is the space into which you're injecting and what is close by that you don't want to be in contact with your injectates, especially if it's alcohol.
Hi, David. That's Fabian.
Oh, sorry I missed your call, sir.
No worries. So the reason why, and I can't ask any good questions about your lecture because I thought I'm logging in early, but I logged in late because of the time shift. The calendar hadn't been adjusted. Either way, how are things going? You're doing well?
Yes, we're doing fantastic. I'm not sure when you were able to log on, but we showed some cases that we've done here already.
Yeah, I only caught the past few months. Good. I'll give you a call later today. We can chat a little bit more.
Perfect.
Thank you.
Sure. Thank you. Any other questions from people online or people here?
Maybe a question for because I see Eva from Uganda is logged in. Eva, do you see any patients with pain? Do you feel like you could get referrals for any of these procedures?
Yeah, definitely. There are always patients who come in with pain. We haven't offered them many options, so this lecture is very enlightening. I think so far we've only done a celiac axis block, maybe 2, yeah, but that's it.
Good. Next stop, Uganda, David.
Yes, exactly.
Yes,
I mean, we let the public know, right, somehow that we were going to be managing pain this week. And I mean, I think we saw like 100 patients in the last 3 days. I mean, we just see patient after patient after patient, and some of them have cancer and some of them don't. And I mean, there are just a lot of people and importantly, Fabian and everybody, importantly, these patients that we're seeing are patients that are going to do well after our procedure. They're not these gray area patients where you don't know if they're going to do well or you're not sure what's causing their pain. These are really textbook descriptions and radiological correlates that lend themselves to these interventions. So, so there are a lot of patients that we can help. We have barely scratched the surface.
That's awesome. Well, I hope then that many of them will be seen in follow-up in clinic, and then you can get the good news.
Yes, yes, absolutely. And we'll follow them up not only to document that they've done well and they were safe following our initial procedure, but oftentimes patients need 2 or 3 things done in order to get their quality of life optimized. So we'll definitely be following them.
Just for my interest, from all these patients you've been seeing, have most of them come out on their own accord, or are they being sent by other doctors? And if so, from which specialty mostly?
So that's a great question. So Juana and Aza, Fabian's question is, the majority of our patients, have they come on their own accord or have they been referred? Yes.
Yeah.
Yes, they're coming on their own. And so almost everything that I have experienced so far in Tanzania is an exact mirror of how it works in the United States. Patients come on their own because they have pain and they want to be managed. And before they got to interventional radiology, they came across some other doctor who has that binary approach that I discourage so much, whereby they say, oh, you know, we do X, Y, and Z, and I don't think that will help you, so good luck. And so then the patients are dispatched to the universe to figure this out for themselves. And then when they present to us with a symptom, we have a much more algorithmic and organized way of painting it into a corner and doing something.
Really amazing. I'm glad this worked out so well.
Yes, Mark.
Yeah, I have a question about the intervention on this.
Yes.
Yeah, you said that this time we are no longer do those intervention. But I just want to know why the reason.
Yeah, so great question was, why are we not talking about interventions for the disc? So 3 things to say about that, Mark. The first one is, it absolutely follows every single principle that we have talked about. It is what is the pain generator? What is the nerve that transmits that pain to the brain? And can we get there and interrupt it? That's exactly how this basivertebral nerve ablation idea evolved. So somebody really smart, after all of these years of futility, somebody really smart said, there are nerves that, drain is the wrong word, carry the pain from the disc. And they're called basivertebral nerves. And then can we get to them using that's our approach, right? Can we get to them? And the answer is yes, we can get to them. We get to them through this transpedicular approach. And then somebody invented a device that you can use to ablate those nerves. Exactly how we're approaching knee pain, exactly how we're approaching medial branch pain, just for a different nerve. So the reason we're not doing it, it's new. So this thing that was invented, the basivertebral nerve ablation device, was called Intracept in the beginning, may still be called Intracept, was recently purchased by a big company, Boston Scientific, and we just don't have an Intracept machine yet. That's all it comes down to. Everybody who's done vertebroplasties here already can do it because that's the approach. We just have to have that equipment. I don't do basivertebral nerve ablation just because I haven't learned how to do it yet. I haven't trained. I don't have the machine myself. It's very, very new. But there are millions of patients who will benefit from that therapy as it continues to disseminate. So both you and I will be doing it within the next 5 years for sure. Right. I've never done a case, so that's why I don't have a slide. But I need to get it in there.